Let me introduce Dr. Radhika Natarajan. She is the Deputy Director, Department of Cornea and Refractive Surgery, and Head of the Department of Teaching and Training at the Shankar Nethralaya, Chennai. And she has 25 years of experience of being a clinician, researcher, a student mentor, and she has to her credit several books which she has authored and co-authored. Her basic areas of interest are corneal infections and inflammation. So over to you, Dr. Radhika.
Thank you for that kind introduction. Hello all, I'm Radhika from Shankar Nethralaya, and special thanks to Dr. Somshila and the scientific committee for having me here. I'll share my screen right away. Can you see my slides? Yes. Can you see my slides and am I audible?
Yes, we can.
Yeah, okay. So the last case and my presentation for today will be a case of xeroderma pigmentosa. So xeroderma pigmentosa, we know, is a rare autosomal recessive disorder. But it is important for us cornea clinicians because many XP patients have corneal problems. And basically, when ultraviolet light damages DNA in the cells, normal cells are able to repair that. But due to an enzymatic defect, XP patients are not able to execute that repair. And the nuclear material gets strewn about in the cells, and that induces malignant changes in epithelial cells. Apart from widespread cutaneous involvement in the exposed parts of the body, the other important site of involvement seems to be the corneal limbus. And because of this, these people get epithelial problems like SPKs, epidefects leading on to corneal ulcers, and the limbal instability also causes ocular surface tumors. All these were seen in my patient of xeroderma pigmentosa, who was also a single-eyed patient. So basically, he was a 45-year-old male patient. He was a known case of xeroderma pigmentosa. He had multiple hyper and hypopigmented macular papillar lesions in his face and his arms. He had a couple of those big black lesions on his eyelids as well. And he was on photoprotective treatment when he presented to us. One eye, he had lost to corneal infection long back. And in the second eye, he had undergone multiple procedures, which included a couple of keratoplasties and a cataract surgery, all of which were done elsewhere. He came to us with acute reduction in vision in his only seeing eye. And this is what we saw, that there was a large and deep infiltrate in the corneal graft, limited to the graft area itself. Also noticeable were two small areas, nasal bigger than temporal, two areas of keratinized OSSN-like lesions. However, we did not know whether they were just dysplastic lesions or whether they were actually invasive carcinomas. We did a corneal scraping, which came positive for Aspergillus flavus, and we started him on two topical antifungal agents in the form of natamycin and voriconazole eye drops, along with supportive medication. The culture also showed fungus. Unfortunately, he did not respond at all to the medical treatment, and we were forced to take him up for therapeutic penetrating keratoplasty. We did a large TPK graft, and also we did an excision biopsy of the suspected OSSN lesions. We gave a wide excision margin, and we adopted a non-touch technique to avoid spilling of seeding over of cells inside the eye. And we also did a cryo application freeze thaw technique to the edges. And we continued the topicals post-operatively. The corneal button also grew fungus, and histopathology showed invasive squamous cell carcinoma with reasonably clear margins. Post-operatively, the corneal graft, under very close watch and plenty of lubrication, did epithelialize completely. You can see that in this picture over here. And the post-operative period did not show any recurrence of the fungal infection or recurrence of the small OSSN in the excised sites. However, 3 weeks later, when the patient came to us, as you can see in this picture over here, he developed multiple whitish patches, leukoplakic-like lesions, especially on the eyelid, which you can see in this picture, and also in the nasal and temporal conjunctiva, which you can see in the picture that I'm going to show you next. So we were wondering whether this was some kind of recurrence of dysplasia that is happening in a site that is different from the previous excision. His systemic workup under the care of an oncologist came out normal. And the oculoplastic colleague wanted to actually take biopsy from the lid to look for evidence of malignancy. Then we figured out that the patient was on voriconazole eye drops, and voriconazole drops as well as systemic voriconazole are prone to cause dysplastic changes. So we went easy on the drop, we stopped it and continued natamycin alone. And you can see in the picture below that the whitish patches in the leukoplakic exchanges on the lower lid have disappeared completely. So the points to ponder in this case were xeroderma pigmentosa, it is better not to do a keratoplasty, but if it had to be done, the primary surgeon who did the PK, would they have been better off doing a limbal support procedure along with the transplant? We had an in-house debate and we thought no, because these limbal transplants have to be allogenic and they would require immunosuppression. And in a disorder which is already so prone to malignancy, it would not be a good idea to give prolonged immunosuppression. And it's really not all or none. We saw that the therapeutic graft did epithelialize over a period of time. So we could do the PK, wait and see. If there is a hint of persistent epithelial problem, we could jump in and do an AIOS or something. We have Dr. Sangwan's paper on it, which I have referred later. And the treatment of the OSSN itself, when you have a corneal ulcer needing a TPK, do you want to give topical chemotherapy? Because in the presence of an ulcer, also these are very toxic medication. Already this epithelium is an unstable epithelium, so you don't want to use these drugs. But at the same time, doing a surface excision along with an intraocular procedure also carries the risk of seeding, which till now has not happened in our patient, but we are keeping our fingers crossed. And lastly, voriconazole also leads to dysplasia topically and systemically. It is a photosensitizing effect which leads to dysplasia, which is very much same as the photosensitizing dysplasia caused by the XP as a disease itself. So probably this drop should not be used in this disorder at all. However, our patient also showed, and reports also show, that voriconazole-induced dysplasia does stop with cessation of the medication itself. So in XP, limbal support or not with PK, OSSN surgery and TPK surgery together or not, and voriconazole or not. So the expert panel, please share your opinion on these.